So very good evening to all. So I also want to get some response in between so that that will really help me to proceed with. Is that okay? Yeah, somebody from the participants, if they respond, that would be great.
It will be probably okay, ma'am.
That's not. Yeah, thank you. So today I'll talk about Mental Health Care Act. I think most of us are familiar with. So I think that I'll try to touch upon the major points because it will be a little difficult if we try to cover all the sections and chapters. So maybe, oh my God, my slides, why it is not moving? Yeah. So thanks. So maybe before we get into this Mental Health Care Act, some historical background. So how we have reached over a period of time to this level of mental health care in India. So that would be really helpful. That's what I thought. Maybe this mental health legislation has existed in India since the mid 19th century. There were a few legislations were existed in 1858 to 1891. And the major aim of this legislations were, they were enacted to regulate the transfer of British patients with mental illness back to England. So, but most of these legislations were detained the patients for indefinite period of time, and most of them were living in a very poor living conditions. So there were very little chance for recovery and discharge. So these are the backgrounds which leads to the formulation of Indian Lunacy Act in 1912. So maybe this can be considered as the first proper law that is governed mental health in India. So, however, this legislation, maybe this is the legislation where the journey began, where now we have reached the formulation of Mental Health Care Act in 2017. But what happened in 1912, this legislation is majorly focused on protecting public from the mentally ill people, because they consider mentally ill people are dangerous to public. So this was actually highly critically criticized by Indian Psychiatric Society, that led to the formulation of another legislation, that is Mental Health Act in 1987. So the major criticism that the 1912 legislation neglected human rights of persons with mental illness. With that background, they have formulated Mental Health Act in 1987. So it came forth and which give more emphasis on the care and treatment of mentally ill persons, and also give more importance to the guardianship and management of property of mental persons with mental illness. So, however, this again lacked some important points, especially the liberty of persons with mental illness, majorly human rights aspects, and which did not really provide any provisions of rehabilitation. It's talked about treatment, but it did not talk much about what happens after discharge from the hospital. So and this also actually failed to consider the financial, social and emotional burden to the patient as well as the caregivers, because it did not allocate funds and resources, and it also kept quiet on emergency psychiatric services, and not much talked about the burden on family, because after discharge it did not there were no clarity about what will happen to them, and there were no provisions were clearly mentioned in that. So maybe I'll come to that slide later. So in 2006, as a result of UN Convention on Rights of Persons with disability. So this rights, there was an agreement which recognized, protects, and supports the rights of persons with disability. So India has ratified it in 2007. So that actually forced us one or other way, I would say that. So we are supposed to ensure that most of our legislation should be in compliance with the UNCRPD. Maybe after, because of this, so we have decided to replace with a new mental health legislation. And the major objective of this mental health legislations, that is how the Mental Health Care Act 2017 were formulated and enforced. So the major objectives were to provide, for mental health care and services for persons with mental illness, and to protect and promote and fulfill the rights of mental persons with mental illness during delivery of mental health care services, and also the matters connected therewith. So if you look into these three legislations, just a minute. Legislations, there are Indian Lunacy Act, which has 8 chapters and 101 sections. So the major objective was to protect public from mentally ill, and definitely it lacked human rights perspective. So the second legislation was Mental Health Act, and which has 10 chapters and which discussed in 98 sections, with an objective to address that neglected human rights. But again, that was it could not address the way it actually supposed to. So then the latest legislation is Mental Health Care Act, which has 16 chapters, 126 sections, and I have already mentioned the objectives, and we will come discuss about the limitations in the end of this presentation. So there are a few timelines related to Mental Health Care Act 2017. So 7th April 2017, this legislation got assent from Honorable President of India. 29th May 2018, it actually got enforced, and rights of persons with mental illness, that is heart and soul of this legislation. Central Mental Health Authority, Mental Health Review Board, State Mental Health Authority, all these rules were notified. In 16th August 2019, there are 2 important statements were notified, that is what assessment of mental capacity and essential psychotropic drugs, those were notified. And the latest in 18th December 2020, Central Mental Health Regulations were notified. These are the major timelines which we need to remember when we talk about mental health care act. So this has, as I said, this has 16 chapters. The first chapter deals with the definition. They have given a lot of definitions, but I've just picked up a few important definitions. These are the major features of this legislation. So advanced directive, we will talk in detail later. And mental health professional, they are well defined who is a mental health professional with their qualifications. So they have mentioned psychiatric social workers, psychiatrist, psychiatric nurse, clinical psychologist, and so on. And they defined mental illness, which is different from other legislation. So the definition, what they have given is mental illness means a substantial disorder of thinking, mood, perception, orientation, or memory that grossly impairs judgment, behavior, capacity to recognize reality, or ability to meet the ordinary demands of life, mental conditions associated with the abuse of alcohol and drugs, but does not include mental retardation. If you see the earlier legislation, they have included mental retardation also in the mental illness. So that is how it is different, and they give a more elaborate definition of mental illness. And mental health care, they define, which includes analysis and diagnosis of persons mental condition and treatment, as well as care and rehabilitation of such person. So earlier legislation, they didn't talk about aftercare or rehabilitation. So this legislation talked about the rehabilitation and talked about the provisions of rehab and community living. And they also defined various terms like minor, prisoner with mental illness, relative, caregiver, and so on. The second chapter, which actually deals with mental illness and capacity to make mental health and treatment decisions. So the legislation, what it says that the determination of mental illness or diagnosis should be in accordance with the national or internationally accepted medical standards. For example, use the diagnostic criteria of ICD-10 or ICD-11. So those are internationally, or DSM, those are internationally or nationally accepted, diagnostic standards. So they have also mentioned that it should not be based on political or we cannot diagnose based on the political or social or religious basis, and past treatment hospitalization should not justify the present or future determination of person's mental illness. And mental illness itself is not going to say that the person is of unsound of mind unless a competent court declare that. So these are the special features of this legislation. So the another important thing is capacity to make mental health care and treatment decisions, which it's majorly from a right-based perspective, because this legislation talks that all individuals have the capacity or freedom to take decisions until and unless under some circumstances, if the person is not able to comprehend the information, and if the person is unable to weigh the consequences of his decision, and if he's not able to communicate the decision, under these three circumstances, this person can be considered that has no capacity to take decision for his welfare. So in that condition only, another person, a nominative representative, NR, or a family member can take decision on behalf of patient. Otherwise, patient has full liberty to take decision on his treatment, admissions, and what kind of treatment, how the treatment has to be done. So he has the full freedom, or she has the full freedom on that. So the third chapter is, it's a unique feature of this legislation, is about advanced directives. So advanced directive is, it's talk about, so how a person wishes to be cared and treated for mental illness, how a person wishes not to be cared and treated for a mental illness. A person with mental illness, when they have a good capacity to take decisions, they can make advanced directives for themselves. It can be taken into consideration when they take treatment and when they don't have a capacity to take a decision. So they can talk about what kind of treatment they opt when they are mentally ill, or when they don't have the capacity, where they want to get admitted. So what kind of medications they prefer to, so what kind of medication they don't want to get, so how they need to be cared. So all these things they can write it, and they need to register this with mental health review board, so that at the time of admission, if the person is not have the capacity, that will be make available to the mental health professional through nominated representative, so that the treatment can be, again, it stressed on the human rights of the person. So this advanced directive is not something which is permanent, which can be amended anytime by the person or mental health review board. That is a implementing authority. So both of them can amend or cancel this advanced directive anytime, based just for the welfare of the patient. So the main responsibility of nominated representative, who is chosen by the patient to take care of them. So they can their responsibility to provide the advance directives to the treating doctor when the patient has no capacity to take decisions. So this is about advanced directive, and advanced directive will be considered null and void if it is not really, if it is contradicting with the legislation, and it definitely will not apply if the patient require any emergency treatment. So these two situations, advanced directives will not be applicable, or if it is not in ally with the legislation, then it will consider as null and void. So I talked many times, mentioned about nominated representatives. Nominated representative can be anybody who is nominated by the patient. It can be a relative, caregiver, or family member, or a friend, or any suitable person, uh, which is who is appointed, by the board for the welfare of patient, when treatment decision needs to be done, when the patient has no capacity to take decisions. So if consider, for example, if a person, homeless person, a wandering mentally ill, so they may not have a family member, or they may not be in a position to have a nominated representative. If they don't have, then the mental health review board will appoint the director of Department of Social Welfare or any designated representative as a nominated representative NR for the person with the mental illness. So the major duties of nominated representatives are, they should, first of all, they should agree that they should accept the responsibility, and they should register their name as a NR for this particular patient with the mental health review board. Second thing, they should support patients, treatment, admission, discharge, rehabilitation, and all the process of mental health care and services. So they can seek information regarding admission and treatment from the mental health establishment or mental health professional. They can approach mental health review board on behalf of patient. They can appoint a suitable attendant for the patient, and they can consent for research only if the patient has no capacity to consent. So if patient has no capacity to consent or take any decision, then only the nominative representative have a role to uh, uh, work on behalf of patient for the welfare of patient. So chapter 5 is the heart and soul of this legislation, which talks about rights of persons with mental illness. So it's a right to access mental health care, which is affordable cost with quality. And suppose if it is not available, the compensation has to be provided in taluk or district level for seeking help somewhere else. That means the government has taken the responsibility of the care of persons with mental illness, and they have the right to live, community living. Government has responsibility to give legal aid, halfway homes, group homes, and they should be protected against from abuse, physical, verbal, sexual, and they should get a safe and hygienic environment. They should have recreational and educational no provisions, privacy, clothing. There should not be any compulsory shaving of head hair, and they have the freedom to choose what kind of clothes they want to wear. It's not necessary the uniform which provide by the hospital. And there are many rights, like right to equality. The mental illness should be treated equally as a physical illness. The government is supposed to responsible to provide all the emergency facilities, including ambulance, adequate appropriate living condition, which is similar to physical illness. They have the right to information, and restriction on release of information in respect of mental illness. They have the right to access medical records, personal contacts, communication, legal aid, and they have the right to make complaints about the deficiencies in provision of services. And right to confidentiality is very important, and which can be breached only in under certain conditions, like if the person is dangerous to self and others, then the person who can get harmed need to be informed. And referral to other hospitals, if it is making referrals, then for the treatment purpose, information needs to be shared. And when in a medical emergency, when the person is threat to public in judicial proceedings, only under these conditions confidentiality can be breached, otherwise it cannot be breached. And the basic medical records can be availed by the persons with mental illness by giving an application to Mental Health Review Board. And it clearly mentioned that nominated representative NR has no right to get medical records of persons with mental illness. So these are the major rights of persons with mental illness. And this I will just run through. So there are implementing authorities, a central mental health authority, state mental health authority, and mental health review boards. These are considered as implementing authority, and mental health review board is a quasi-judiciary body which regulates mental health establishment, admission, discharge procedures, and regulates the prohibited treatment. All these things will be dealt by this mental health review board. And the government, definitely, I have already mentioned, government has the sole role, the major role to provide mental health care and services to the population. So in terms of promotion, preventive aspect, awareness, and so on. So when it comes to mental health establishment, so mental health establishment, according to this legislation, any structure or any residential place apart from family where the patient is going to stay overnight is considered as mental health establishment. So any structure which is going to provide overnight, care or stay for persons with mental illness should be registered under this legislation. And there are two types of registration: provisional, which is still the norms are notified. Once norms are notified, they can go for the permanent registration. So sorry. So there are finance account audit. I think it's about grants and funds, annual reports and all that. The other important thing is admission, treatment, and discharge. So there are two types of admission under this legislation. That is independent admission, otherwise called voluntary admission, and supported admission. In other words, we can call involuntary admission. So independent admission, there are two types. Independent admission of adult. If an adult gives consent request for admission, he has to be or she has to be examined by a mental health professional and admit for the treatment and care. So minor, in case of minor children below 18 years, nominated representative, that is their family members, can request for admission in patient care. Two mental health professionals should examine independently and admit the minor. So in case of minor, this admission needs to be informed to mental health review board within 72 hours. That is compulsory. So once we come to supported admission, that is involuntary admission, when patient has no capacity to take decision. That also there are two types of supported admission, that is up to 30 days and beyond 30 days. So that will be on request of nominated representative, because patient is not in a position to take decision, appropriate decision. And if it is up to 30 days, a psychiatrist and a mental health professional should examine the patient and admit the patient. If it is beyond 30 days, two psychiatrists to independently examine the patient and come to a consensus whether it needs to be continued, the admission needs to be continued or not. So the both ways, if it is up to 30 days or beyond 30 days, mental health review board needs to be informed within stipulated time period, that is 1 week and 72 hours. So in chapter 12, in section 94, which talks about emergency treatment. So emergency treatment can be given a period of 72 hours, maybe at home or in the hospital. And after 72 hours, so the patient need to admit as voluntary or involuntary admission, that is independent or supported admission. So another section is section 95, which talked about prohibited treatment, that is psychosurgery is regulated. It can be considered only after the consent from the patient and the clearance from mental health review board. Physical restraint, it should be considered as the last resort, which should be authorized by the psychiatrist. Generally, a patient can be physically restrained. Unmodified ECT without anesthesia is totally prohibited under this legislation. Sterilization, chaining, speculation, solitary confinement is totally prohibited under this legislation. ECT for minor also regulated under this legislation. It can be given only after the consent from the family member, that is nominated representative, and also should get clearance from mental health review board. And the duties of police and magistrate, if a homeless person or a wandering patient or a threat to public, then police has to get involved and try to find the family members. Otherwise, need to inform mental health review board, and mental health review board appoint a nominated representative. And this group of population needs to be admitted to a public hospital and get treated and consider for rehabilitation. And it also talk about prisoners with mental illness and all, so on. So it also restrict the functions of professionals. The legislation clearly said that no mental health professional or medical practitioner shall discharge any duty or perform function which is not authorized by this act. So if it do so, it can lead to, it can consider as an offense and lead to penalties and punishment. So penalties are majorly if the mental health establishment is not registered, then penalty is there. If mental health professional knowingly work in a mental health establishment which is not registered, and any other thing which is not in LA with legislations are considered are offenses and liable to punishment. So other provisions like decriminalization of attempt to suicide, everything comes under the last chapter, miscellaneous. So this is just a nutshell about this legislation. I don't know how much more time I have.
Under 15 minutes.
50 minutes. Till now, any clarification? So you can ask maybe one or two, or we'll ask the clarification in the end. How it will be?
At the end.
At the end. Okay.
Okay. So
this is just a brief about this legislation. As we know that once we see the historically, if you see like that, we have come a long way in terms of mental health care and services in India, and this is this new legislation really gives a lot of importance to persons' rights, and it's more of right based. But definitely there are a lot of dilemmas and questions, there are so many things which is not clearly answered. So if you see it like critically, so they have given definition of mental illness, it's clearly mentioned. But when we consider anxiety disorders, personality disorders, definitely they don't have much difficulty in terms of taking decisions, not very gross dysfunctions. And the Mental Health Care Act also says that determination of mental illness as per national and international guidelines. So there are a bit contradiction in terms of the definition and how they give the guidelines to determine mental illness. Sometimes I feel it just contradict some of the definitions and some of the disorders and the diagnostic guidelines, if you see. So, and we talk about capacities. So the legislation clearly mentioned about the three conditions. If the patient is not able to comprehend, not able to communicate, and if unable to weigh the consequences, then only they can be considered as no capacity. So if a patient has a capacity and he or she denies treatment, then what we will do? Whether we need to treat, whether we have the power to treat, definitely no. That is again, we do get patients who has capacity and who say like that, I don't need any treatment. So that is again put the mental health professionals into a trap. And if patient has not nominated representative, now I think it's just getting into this action. So we do face these difficulties. Now we consider the family member as nominated representative once it get into enforced and full-fledged. So if there are patients who have not nominated, if they don't have advanced directive, so what we will do in that? So that can delay in treatment, that can demand for more resources. Do we have that or not? That is again a question. And how many of our patients are aware about the provision of advanced directive? They have the power to write advanced directive and they have the right to to see whether what way they want to be treated and what the way they don't want to be treated. I don't know how many of them are aware about whether are we doing anything to create awareness on that. And even if they are aware about advanced directive, how many of our patients have adequate information about their illness, treatment options, side effects, and which is a better treatment, how it should be. So if they have to write a proper advanced directive for their welfare, then they need to have adequate information. And sometimes I always feel like that it's social culturally whether it is really appropriate or not. And the economic impact. Suppose a patient has written, I need to be treated in such and such hospital when I am not having the capacity. If the family or nominated representative is not economically well off to do that, because in foreign countries, it's more of this legislation is similar to the legislations of Europe and all that. So they have insurance facility, but do we have? Though the legislation give the provision of insurance, but whether practically it is implemented or not. So that is again going to be a difficult. And advanced directive can be revoked and amendment can be done anytime, whether that will affect the continuity of treatment or not. So it is a good idea to just look, there are a lot of pros and cons of advanced directive when we look at this current moment of implementation. And treating professional, they have no say at the time of admission, but they are more made responsible at the time of discharge. So that also really put the mental health professional into a confusion. And as we know that maybe before this legislation, so if a person has no capacity or violent or creating issues, the family take a collective decision on behalf of patient. So the concept of nominated representative, a single person is going to be responsible, whether that is going to increase the caregiver burden and the family, how the family is going to take it up. It's suppose a patient nominated a particular person, other persons, people are also taking care of the person. So how they feel, so how it is going to impact patient care and support. And nominated representatives, their intentions, awareness about mental illness, their rights, and what are the things they are supposed to do, not to do, their awareness about treatment history of the patient, treatment options. So all these things really matters. And it also says as a right of persons with mental, no compulsory shaving of head. So most of the times, when we see, for example, NIMHANS, I have more exposure to NIMHANS. So we do have clues what we do have people who are homeless, wandering mentally ill. So in that case, I think shaving of head, it's good in terms of hygiene perspective. So though it allows, legislation somewhere allows that, but still if patient really don't want to do that, there is no, that is again difficult. Forcefully you cannot do it. And wearing of uniforms, it sometimes, if it is, there are so many patients, maybe that will help to identify patients. And if we allow them to wear the clothes what they wish to wear, sometimes we decide clothes and uniform based on the risk categories and all that. So when a person or a group of people, they have suicidal risk and they wish to wear, if they allow to wear whatever clothes they can wear, sometimes it will be difficult. So it will be difficult compared to the human resources available, what available for us, whether we do have enough resources to supervise, monitor these patients. So these are from the clinician's perspective, the practical difficulties I'm just talking about. And treatment can be given only by mental health establishment. So how many mental health establishment we do have in the public sector? Maybe we can accommodate only 60,000 maybe in the country wide. So how many crores of population we have? So we say like the 10% of them have mental illness. So earlier, so when there were any emergency, people were able to approach nearby clinics and all that. Now that provision is not there. So the frequency of renewal of license, every year the establishment has to renew the license and pay the money. That is again practically difficult. And the section 78 talk about mental health review board as a judicial, quasi-judiciary thing. So does it mean that the establishment should have a lawyer to make it, if there is any proceeding needs to be done, then we need to have a lawyer. So is that cost effective? And prohibited procedures like ECT, sometimes ECT considered as a life-saving procedure. And when it comes under prohibited, whether that will worsen the stigma against it or not. And we don't admit patients not always for treatment, sometimes for diagnostic clarifications, evaluation, observation. And there is no sections which clearly talk about admissions under these circumstances. So sometimes we feel like that, whether it is trying to say that admit and treat a patient when the illness become more severe and the patient become very unmanageable. So these are the questions usually I used to observe and listen when we talk about mental health legislation, when we try to implement the current scenario. So maybe it will improve later on, because there are a lot of things are happening. So, but it's not mean that it has only negative sides. So it decriminalize suicide attempt and give the provision to prevent the recurrence. And definitely it gives more important to the human rights of mentally ill, and make it more affordable, accessible, and government has more responsibility to implement this, so that there will be a sustainability of things, and more healthcare centers may come up, and access to free legal services, medical records. All these things are really commendable. So advanced directive, definitely if they have proper education and awareness, that really empower the person. So people will start asking about what treatment I'm going through, what kind of illness, that really empower them to get more informations about their illness, treatment, and all that. And restricted use of ECT means unmodified prohibition of unmodified ECT is something which is really commendable. And free quality treatment by the government sector in confidentiality, and the special provision for women, like not separating women from their children. Only if it is absolutely necessary, if the person is going to harm the child. Otherwise, no, they have the right to keep their children along with them during treatment. And it also ensures mental illness people will receive proper care, treatment, and after discharge, the rehabilitation facility, they talk about halfway home and community living. Though it is not well established, but the provisions are there. That means definitely government will take steps to ensure or enforce that. So that is one important thing. So that will ensure the recovery process of this group of people, and that will really give or respect the dignity of the people with mental illness. So if you just sum up, there are three legislations were there with different timelines, different years, with different objectives. And maybe the first legislation which focus more of custodial care of mental illness. It's majorly not for treatment, but it's majorly to protect the public from mentally ill. We do not give much importance to the human rights. Later on, it is modified and give little more importance to human rights, though there are lacunas, but it gives more importance to treatment of mental illness, though it did not talk about the rehabilitation and aftercare. Later, the Mental Health Care Act, which attempted to ally with UNCRPD, focused more on human rights of persons with mental illness. So I definitely strongly believe that this legislation will help to help our country to come up in a more with more rehab facilities, and more facilities for mentally ill people, and mentally people with persons with mental illness will be empowered, because they need to know about their illness, treatment, diagnosis, and all that. So that way the legislation, maybe in coming years, once it get enforced and implemented, provisions will be implemented properly. So that way it is really a good legislation which give more scope to the rights of persons with mental illness. So these are my references. I hope I'm in time.